meta-analysis, where they looked after about 12 studies, they found the following. All studies who compared CCK with hinge knees. There was no difference in survival, complication rate, and range of motion. CCK has a slightly better function and pain, but at the end it's the same. So as you all know, I got this slide from Pablo Sanz from Madrid. You have really to accept the indications about the patient. Is it infection? How radical do you have to debridement? Are the collaterals are there? But is it still true? Should we only implant a hinge knee in case of revision in those indications? I did this here 2019 in Guayaquil. I decided to use the hinge knee because it seems to be better. And that's why I'm talking about the rotating hinge knee, the endo model. I was talking about it many times. Sometimes you have to choose, if you do a knee revision, even a pure hinge knee, if you really have a huge amount of instability. And again, the results are comparable. So at least in mine, and I know in US and here and all over the world, the threshold to implant a hinge knee is quite high. I have a very low threshold to implant a hinge knee because if you take a look at the literature, most of the papers show, as I mentioned before, comparable results. For example, that's a paper from Jan Bellemann's group in Belgium, who compared rotating hinge knee with CCK knee, and he came to the conclusion that if you operate an arthrofibrosis and really do this really thoroughly, then a rotating hinge knee is significantly better, have better postoperative results. But sometimes a hinge knee can loose. So that's another point of revision, when you have to decide what you have to choose. That's a patient, he came to me, a high-risk patient, BMI 43, 140 kilo, heavy smoker, received somewhere else this joint replacement. 4 months later it failed. They put in a hinge knee there. They get out of the condyles, as you can see here, without any reason. 4 months later, it was getting loose in the tibia and in the femur, and 8 months later, she had a severe loosening. And then you have to consider the following. A hinge knee, especially a cemented stem, can be loose after a short time under some circumstances. My colleague Mustafa Sitak published his classification, and so if you do some kind of revision and you have a very wide canal, more than 20 millimeters, 20 centimeters up of the joint line or down of the joint line in the tibia, don't put in a hinge knee because the loosening rate is significantly higher if you cement a stem in a very wide canal. He has published it, or we published it for the femur and the tibia as well, and then you have the problem and you have a loose hinge. And that makes really difficult. If you have bone loss, in kind of knee revisions, we all know that the main reason for bone loss is osteolysis, of course. As you can see here, after 12 years, huge kind of osteolysis. We all know the classifications about osteolysis in case of revision. There are one, the Aori classification, and more recently, the zone classification published by William Morgan Jones in 2015, where he divided it in 3 zones, depending on the defect. Zone 1 is joint surface, zone 2 is metaphysis, and zone 3 is diaphysis. For example, here it's a zone 3 defect, that means the diaphysis is. And depending, to be honest, depending on the defect, you have many choices in knee revisions. And we will later talk about wedges and cones. You can make it a little bit more biological. You can use augments and sleeves and so on. So we use, in the meantime, we use a lot of cones. I'm coming later back on it around noon because the papers, they all support the usage of cones in case of revisions. And it's because cones, I'm talking later about it more in detail, are really, really good short-term results. You can use them with all implants, and even here in this case with a loose, very, very loose stem, in this obese lady, we use cones in combination with impaction grafting, or we use mega prostheses like this system. And here in this lady, I used cementless revision stamp in the femur and did some kind of impaction grafting and tibia cone in the tibia. So if you all put it all together, a rotating hinge, if you compare the revision implants, are probably the best regarding survival rate and complication rate. So, and then I'd like to show you this study that I got from Madrid, where they looked and compared 50 patients. They compared CCK knees with the endo model, with the rotating hinge knees, and they came up, and make a long story short, here you see, I can better read it as me, that the results within the rotating hinge group were much better than in the LCCK group. So the conclusion, at least of this study, was probably, if you are in doubt, you should use the more constrained implant in revision, and that's my advice. And thank you very much. Muchas gracias.